Well, welcome. We're here at the final Healthcare 101 webinar focused on improving adolescent and young adult health care through partnerships, something we all know well about. This builds on some previous partnerships that or webinars that we've covered on the overall healthcare system that serves adolescents and young adults, look at clinic quality improvement and public health's role, and our last webinar on Ideas in Action in Ohio, where they have a quality improvement effort that's managed by their state American Academy of Pediatrics chapter, and the impact of partnerships on that work. So today, we're going to delve into partnerships. And you might ask, well, why are we doing this? Public health and healthcare partnered in many areas for many years, but outside of young people with special health care needs, immunizations, and school-based health centers, there's really been little focus on adolescents and young adults, especially in that healthcare and public health partnership. So today we're going to do an overview of the models and examples of state partnerships that bring together all of those folks that need to be together to improve access, quality, and equity of health care for youth. My name is Kristen Teipel. I direct the State Adolescent Health Resource Center at the University of Minnesota, and I'm joined by my colleague, Rena Large, who's working in the background with me, and we're facilitators for the webinar today. This session is part of a learning community about creating youth-centered care. It's brought to you by the Adolescent and Young Adult Health National Resource Center, which is a partnership between 3 universities, University of California, San Francisco, Vermont, and Minnesota, and the Association of Maternal Child Health Programs, or AMCHIP. And you can see the link to our web address for that. So through our center, we work together and to support people like you and your partners as you improve health care for young people ages 10 to 25. We are funded through the Maternal Child Health Bureau, and we appreciate their support for this webinar today. So just to set the stage, youth-centered care is really how we weave together the standards for health care, the right thing, doing the right thing, or evidence-based care, with the qualities that young people demand, care that's done the right way and designed for young people. Good clinical care done in a way that connects with and meets the needs of young people is youth-centered care. So as we're focusing on that, please listen today about how our partnerships are working together to address things like helping all young people have access to the care that they need, provided by staff and providers who have the attitudes, skills, and knowledge to do that good care, and that care is driven by guidelines that we know is evidence-based, likely to make a difference. It's provided in ways that support young people's confidentiality at the same time as linking them to the adults that help them make good decisions. It's provided and reached out to young people through strategic communication, and it's done in ways and places that are welcoming and inviting to young people. And finally, that care really involves young people in their own health, both in the visit and understanding how to use the healthcare system and taking their health to the next level. So our topic today, Healthcare 101, leveraging state partnerships to improve healthcare and outcomes for adolescents and young adults. We are joined today with our presenter, Dr. Wendy Davis, who's a colleague of ours at the Adolescent and Young Adult Health National Resource Center, but she's also a professor of pediatrics at the Larner College of Medicine at the University of Vermont, and more importantly for today's work, the Associate Director of the National Improvement Partnership Network. While she's been practicing general pediatrics for 20 years in Burlington, Vermont, she's also a founding member of the Vermont Child Health Improvement Program, or VCHIP, which provides population-based MCH services in research and quality improvement. Wendy's participated in and served as faculty for numerous maternal child health quality improvement projects and has fulfilled many roles in the Vermont Department of Health over the past years, serving as both the director of the Maternal Child Health Program and the Vermont's Commissioner of Health. And finally, she's also served in state and district leadership roles for the American Academy of Pediatrics, for which she is now currently a District 1 chairperson. So as you can hear, Wendy is just an extremely qualified person to talk with us about partnerships. So welcome, Wendy. I pass it on to you.
Thank you, Kristen, and good afternoon, everyone, or good morning if by some chance we have folks in even more Western time zones. Thanks for that kind introduction, Kristen, and I want to start by saying it's a pleasure to be with all of you today. This is one of my favorite topics, so I'm excited that we're going to get to address it together. And I do have some learning objectives for you today. I hope by the end of our hour together that you'll feel like you can identify some potential partners for your work in adolescent and young adult health and improving service delivery and outcomes for that population. I'm sure many of you already have engaged partners, but hopefully will inspire you to think about some partners that may not be at your table at the moment. I'm then going to share with you a bit more about our organization, the Vermont Child Health Improvement Program, and improvement partnerships in general, and how you can get connected to them and what they can do to help advance healthcare quality for this population. We'll just talk a little bit about the basic principles that support our organizations, and I'm going to describe some infrastructure for you, and most importantly, again, talk to you a little bit about how you might see potential benefit here to connecting to these stakeholders. And then finally, we'll conclude with describing some strategies, so trying to operationalize some of the information that I had presented already in order to engage these partners and also think about how to sustain collaboration and really make it work for you to improve health and outcomes. So before we delve into that, I think it's worth taking a moment to think about why do we pursue these partnerships? And it's pretty obvious to all of us, but one of the foundational documents that I really like to refer back to is a report that came from the Institute of Medicine in 2012. And this was a group convened by federal agencies, HRSA and the CDC, who were asked to really look at how primary care and public health professionals could become more integrated in order to improve population health. And so a committee was formed. Their charge specifically was to identify the best examples of this type of integration and drill down and try to identify factors that might promote and sustain these sorts of efforts. And for the purpose of this committee in the report, they used a definition for integration of the linkage of programs and activities to promote the overall efficiency and effectiveness, and most importantly, to achieve gains in population health. Okay. Just working to advance here. There we go. So the committee did a tremendous amount of work. They published quite a long report. There's a wonderful executive summary if you go to the link that is probably worth taking a look at if you haven't seen it already. But among the findings and conclusions that are helpful for our discussion today are what you see on this slide. And those are that the integration of primary care and public health could enhance the capacity of both of these sectors to carry out their missions and to link with other stakeholders to catalyze a collaborative movement toward improved population health. So that was really one of the big picture findings. And again, you know, probably not something that's surprising to any of us who do this work, but it was nice to know that this group of experts with lots of content expertise among them really reviewed the research and came to this conclusion after a significant amount of attention to this topic. And they also concluded that there was really no single best solution, that this kind of work requires community-level application of this framework, and there really has to be very significant local adaptation and development of specific structures, relationships, and processes if this is going to be helpful. And that mirrors very much a mantra that we like to use in the quality improvement world. We often say that all improvement is local. And really what that means is simply that we can identify evidence-based practices. We know the outcomes that we want to get to. But in the end, when we're doing the on-the-ground work, we really need to know and understand and connect with our own communities and adapt the evidence so that it will work effectively for our particular location. So I want to start by asking a question. And of the many partners that we work with in our improvement partnerships, what you see here is a list of some of the most prominent among them. And what I wonder is whether you all who've been doing this work have considered these different entities as your stakeholders and potential partners. So certainly healthcare professionals, that's an obvious one. And by that, I do mean the whole array of folks who make up in today's world, team-based care. So not only physicians and nurse practitioners, but for this population, we have to think about school and college health staff, school nurses, and all of the practice and healthcare setting staff that contribute to caring for this population. And I also put under this group the folks who comprise our professional organizations, and we're going to talk a lot about these today, but folks who are members of state medical societies, the American Academies of Pediatrics and Family Medicine, and a host of other organizations, and I'll tell you a little bit more about those. Hospitals and health systems are huge, and of course in today's complex world of health reform, the healthcare infrastructure is evolving rapidly. It seems like every day there's some sort of new structure that people are trying to construct. One of the ones in current parlance is accountable care organizations, where you begin to look at not only the health of patients in an individual practice or a particular hospital catchment area, but really a large group of patients, a population of you, if you will, that might make up a county or a region or even a state, and how to both provide care and pay for care in that sort of structure, with some really innovative ideas coming out for how we might do that differently. So those might be potential partners in your work. Public health professionals, which many of you represent, but are you adequately connecting at the intra-agency level? So have you connected to all the folks throughout your departments who might have an interest in this same target population? And in particular, when we're talking about adolescent and young adult health, obviously some of the partners that come immediately to mind are our colleagues who conduct activities in sexual and reproductive health, alcohol and drug abuse programs. Health surveillance is huge here because we need good data sets such as the Youth Risk Behavior Survey to have the data that we need to drive our planning. So really look throughout your agency and make sure that you've got the right players there at the table. And then finally, well, in state government we have some additional entities. So our state Medicaid agency and the colleagues who work in that organization. And I'll take a moment to remind you here, if you're not aware, that our state Title V programs and the state Medicaid agencies generally have actually an interagency agreement, which might be a place for you to explore identifying opportunities for leveraging, or if you're already doing this, for strengthening some of the existing policies to improve the delivery of services to adolescents and young adults who are served by Medicaid. And the same goes for our education partners, and again, in some states there are interagency agreements between state health departments and agencies of education, so you might explore that as an opportunity. Academic medicine includes a host of partners, not only the physician community, but other teachers and learners who might be interested in helping to do this work. And then quality improvement specialists, and these exist in a variety of organizations. Our improvement partnerships that I'm going to tell you more about is one of these entities, but again, as an example, hospitals and health systems increasingly are employing QI specialists to help conduct that part of the work that they're required to do. And certainly those of you who work in public health departments know that with the advent of public health accreditation, we've begun to recruit and employ performance improvement specialists and folks who really have a very solid background in quality improvement and might be able to assist. And then finally, and of course this is not an exclusive list, but the insurers and the payers really have a very strong stake in this activity as well. They are beholden to meeting benchmarks and measures, and they know that they can't do that without connecting with partners who are doing the work on the ground. So that's another group to think about. So we wanted to pose the question of whether those of you on the call today currently have partnerships with individuals that you see posed on or described on this slide. And Kristen, do we have a way to put that poll question up? There it is. Yes. Okay, so I think if you look on the right, you'll see the different groups, and I believe you're able to select all that apply. So I would love it if you would all take a moment right now to answer the poll and then hit submit in the lower right-hand corner, and we would just love to get a look at what the numbers look like, excuse me, for this group today. And I'm not the poll expert here, so I'm going to look to Kristen to tell me when this is finalized and whether we have numbers that we can display.
And Actually, Rena is managing this, so Rena,
Okay.
I will leave that.
Okay. We have about half of our attendees have participated. You have about 5 more seconds, and then the poll will close. Okay, the poll is closed, and we can share individual results here. Great. This is looking wonderful on 2 counts. One, the fact that many of you do have partnerships in the healthcare community, so particularly with healthcare professionals, with those hospitals, health systems, accountable care organizations, the infrastructure, certainly with your other public health professional colleagues and other state government entities. But it looks like academic medicine is fertile ground for exploration, and identifying more partners for quality improvement, and then insurers and payers. So, and even with the first groups that I mentioned, obviously there's lots of opportunity there, it looks like, to either develop or expand partnerships. So I think what we'll talk about for the rest of the hour will hopefully help move you in that direction. And thanks for participating in the poll. So I am going to focus particularly on healthcare professionals and quality improvement specialists, because those are the 2 worlds that I spend the most time in. But at the end, we will talk about incentives for a number of those other groups. I want to start by talking about the American Academy of Pediatrics, because I think this is a very visible and hopefully reasonably easy structure to connect to in your states and communities. And if you aren't connected there already, to think about this being one of the places that you reach out early on. So this organization, just quickly, was established in 1930, and I say that and want to make a point about the name, because the name reflects the organization's commitment to the interests of our patients, infants, children, adolescents, and families, I really should have there. And that is why it was named the American Academy of Pediatrics as opposed to the American Academy of Pediatricians. We have about 66,000 members in the U.S., Canada, and around the world, and our international colleagues are expanding all the time. And if you ever see the designation FAAP, or FAP, as we like to say, after someone's name, usually that's either a physician or a nurse practitioner, then you know that that person is a fellow of the American Academy of Pediatrics, and they have passed criteria, including board certification, in order to earn that designation. The organization consists of not only general pediatricians, but all of the pediatric medical subspecialists, and so adolescent medicine is definitely a very visible group within this entity, and then pediatric surgical specialists as well. And we are organized into 10 geographic districts, which I'll show you on the next slide. The picture there is of Dr. Karen Remtley, who is the AAP's current Chief Executive Officer and Executive Vice President. And I wanted you to see her because I wanted to remind myself to tell you that Karen, before she came to the AAP in this position, was a state health official in Virginia. So if there's anyone on from Virginia, you might recognize Karen. And she also has a background working with Anthem Blue Cross Blue Shield. So she came to the Academy now, it's almost a couple of years ago, with a really wonderful background and absolutely embraces that concept of healthcare delivery and public health integration. So she's a great champion at the national level for this type of work. This slide shows you how we're organized into those 10 districts, and one point I wanted to make here is just that many of these districts roughly correspond, not completely, but roughly correspond to our Health Resources and Services Administration, or HRSA, regions. And so again, if you're working on activities that where you need to collaborate with partners in your HRSA region, that's where your AAP district and then the state chapters, which I'll show you in a moment, can be great partners in trying to accomplish common objectives. The Academy is a very complex organization, so I won't go into all the different departments and divisions, but I wanted to particularly point out the Division of Community, Chapter Affairs, and Quality Improvement, which you see in red on this slide, and to show you what the Academy considers to be this group's primary function. And these folks really work to foster pediatrician involvement in their communities. They are always working to develop and sustain the strong chapter and district organizations, but really with the goal of forging those partnerships with state government agencies and officials, and to help chapters build capacity to lead quality improvement programs. So exactly the kind of work that we want to be doing in order to improve health outcomes and health care delivery for adolescents and young adults. It's a very defined activity that the Academy is obliged to do by their own organizational structure. I mentioned the chapters. I'm going to tell you a little bit more about those in a moment because I think those are the structures that you can really connect to at the state level. There are 66 of them, and they represent mostly the individual states. New York and California are so large that they each have, New York has 3 chapters and California has 4 chapters, which tells you something about the population. But there's also a Uniformed Services East and Uniformed Services West chapter, so that the dividing line there is the Mississippi River, and so if you want to be working with colleagues in the military, there's a way to reach them. We have 7 Canadian chapters, and then Puerto Rico and Washington, D.C. are also chapters. So there's essentially a chapter structure for anyone that you might want to reach out to at your state or local level. The chapters are independently incorporated, and that's important. I'll show you why in a moment. But again, they are obliged by basically the bylaws and the governance of the organization to focus on that local and state advocacy, but also education, leadership, and networking. So it's really in their work plan to be connecting with partners like you in order to improve care for adolescents and young adults. And each chapter has its own governance structure. They vary a little bit from state to state, but the chapters generally elect their leaders. So I borrowed a couple of slides from the AAP, and this is just a little bit more of a description of what chapters look like. Again, they're all about implementing the AAP policy at the state level, but they do address national priorities, and then they also have to look at what's going on in their specific regions and locations. So again, that piece about improvement being local. Their primary functions are around advocacy, leadership, and education, but as you saw on one of those previous slides, increasingly they are coming into the world of actually conducting on-the-ground quality improvement work and really trying to do work that both improves things at the local level, but then can translate into policy and systems changes that will be more sustainable in their region. And they can be independently incorporated in a couple different ways, and the reason this is important is how they're incorporated does impact their ability to lobby, but even more important, it gives them the freedom to address the needs and interests of their respective members, states, and regions. So if you have an issue that's pretty uniquely in your location, that's something that the chapter folks are likely very interested in as well. This is just a little bit more about their leadership and staffing, and I wanted to show you this for a couple of reasons. The president and vice president, which all chapters have, are unpaid volunteers. Don't feel sorry for them. They love the work that they do, but it means that most of them do have day jobs and may be a little bit harder to connect with initially. And so the great thing is that most chapters also have paid staff in the form of executive directors. And these are the folks who serve as administrators and managers of chapter business, but frankly, in my experience, they do a ton more, and they are often the ones who are looking for sources of funding. They're at the tables when local stakeholders are brought together around child and adolescent health-related topics. They do work, obviously, closely with the president and the vice president, and their duties and their skills are quite variable by chapter, but they are a great place to start, all of these folks, but I would say particularly the executive directors, if you want to get the scoop on who can you reach out to and maybe start to build a partnership with. And then there is also a more complex national structure, but I want to show you a little bit about this really, again, as a resource to think about for a number of different reasons. So the AAP nationally, it has the chapter structure, but then it also has committees, sections, and councils. And these are all a slightly different variation of a structure that brings a local, or a group of experts with a common interest together. And there's sort of a long, complicated history about why we have these different structures, but I pulled out some examples of ones that would be of interest to you in your work, I think. So committees are sources of expert opinion. They develop AAP policy in their content areas. And a great example of this is the Committee on Substance Use and Prevention, which has done a tremendous amount of work around adolescent and young adult substance use. I'm going to show you some of their products in a moment. The sections do very similar work. They also provide a forum for education, practice, and research. And a great example here that you want to be connected to is the section on adolescent health, which focuses exclusively on this population. And then finally, councils. And councils represent some groups that have evolved really where we had both committees and sections historically addressing the same topic, and in the interest of efficiency, we brought them together so that they are folks who are working in the same field, but they're now in an integrated structure. And a great example of this that does a lot of work related to school-age youth is the Council on School Health. So, section on adolescent health, I just wanted to show you their mission. It's really to provide education and resources to assist general pediatricians and adolescent medicine specialists to enhance skills to care for adolescent patients. But, you know, this is the mission with respect to Academy members. Again, underlying this is that drive to connect with the local, regional, state, national stakeholders who can assist in this work. And I give you their website. Much of the Academy's content is public-facing, and then there is some content that is members only. So if you are looking for something and having trouble getting to it on the website, that's another reason to have a quick contact at your local state chapter in order to get to those resources. There's a section on tobacco control, and they have really focused a lot on both tobacco use but secondhand smoke exposure as well. Increasingly, recently, they've focused on electronic nicotine delivery systems, and they do lots of education and training for providers. The Committee on Substance Use and Prevention has just really, as you can imagine, been intensively busy over the past several years. And you can see here their vision and mission statements, really wanting a world in which children and adolescents are free from harms caused by substance use problems and disorders. And so again, they are largely about producing guidance. And here you see not only to pediatricians, but to state and federal governments and other stakeholders to reduce harm from substance use. And so here is just a snapshot. This is by no means an exclusive list of their policy, clinical, and technical reports. These are the different types of documents that the Academy will produce. But you can see it runs the gamut from nicotine use and exposure, parental substance use, binge drinking, adolescent drug testing policies in schools. So again, if you're looking for resources or guidance about what this national body says about these different topics, it should be readily available to you through the American Academy of Pediatrics. And they've done a lot of work in the last couple of years very specifically on marijuana. And I know we in Vermont have found this incredibly helpful. We're one of the many states, and I know there are others of you out there who are on the brink of completely legalizing recreational marijuana. We may have staved it off for this session, but we have found this type of guidance that's available and, again, represents a very significant expert opinion. We've used this in our legislative discussions. So the AAP is my professional home, and I know the most about it, but it's certainly not the only health professional organization that could be a good partner for you. And I call out here some of the other ones that have a particular interest in adolescents and young adults, although, again, this is by no means exclusive. But there is an American Academy of Family Physicians, which has a very similar structure and infrastructure to the AAP. The American College of Physicians serves young adults and then the whole spectrum of the adult population. But we in Vermont have recently gotten more and more connected to our ACP colleagues as we've tried to really be more focused on the young adult population. And then, of course, the American Congress of Obstetrics and Gynecology, or ACOG, which is, again, a great resource for reproductive health information and guidance, and for many other topics as well. Your state medical society, and many states that are larger have county levels of these societies or even more local, city or urban-based entities, they can be a great resource. And I would say that in smaller states like Vermont, a group like the American Academy of Pediatrics works very closely with the State Medical Society, and there's a lot of overlap with membership. In a large state like California, you probably have, you might have 5 different Los Angeles level entities of the State Medical Society because the population is so big. But you can generally find these organizations, they generally have websites, they generally have a similar structure in terms of state-based leadership and executive directors, and so hopefully you can get to these folks as well. And then, again, branching out and thinking about the whole of the team that's providing care to adolescents and young adults. Again, by no means exhaustive, but nurse practitioner and physician assistants have both national and state level organizations. Groups like the National Association of School Nurses, and many of us have state level organizations of those as well. And then again, thinking about your particular hospitals and health systems or other visible infrastructure where health care is being delivered are folks that you should be reaching out to. So we're going to shift gears here a little bit, and I'm going to move us into the section where we're going to talk specifically about improvement partnerships, and I'll define those in a moment because my guess is that many of you have not heard that term, and their very specific role in advancing healthcare quality for children, youth, and families. And as I said, we'll just walk through some of our foundational principles, how we got to where we are today, and I'll tell you a little bit about that infrastructure and the potential benefits for folks who are interested in improving health care for the adolescent and young adult population. Improvement partnerships, we created this definition after a number of these organizations had evolved somewhat organically. So we describe them as a durable state or regional collaboration of public and private partners that uses measurement-based efforts and a systems approach to improve the quality of children's health care. And a couple of notes about this definition. I want to emphasize that measurement piece because the way we conduct our work in 2017 is really the way most of you likely do in your own programs and activities, and that is starting by looking at the data that we can get our hands on that relates to a particular topic of interest and really thoroughly analyzing it to identify what's going well and what needs improvement. So we virtually never undertake a project or an activity without saying, where do we start in terms of the data, and then conducting that analysis and working with partners to see if we have consensus about what that data is telling us. We also very much focus on that systems approach. So we start by breaking apart the system that we want to improve and looking at its component parts and trying to figure out where the leverage points are for improvement, and then putting it back together using tools and methods that are hopefully geared to improve the system performance. And again, we say children's health care, but this really in 2017 has evolved to be about the care of infants, children, adolescents, young adults, and whole families. And what do these organizations do? Well, this is a list of really sort of the basic functions. And again, these exist in many different states. I'll show you the map in a moment. So, you know, in every state they probably look a little bit different, but these are pretty much the core functions that you see here. So we develop if necessary, but if not, we beg, borrow, and steal existing tools and measures and strategies that we know have some evidence base or at least appear to be a promising practice in order to improve an aspect of healthcare delivery or a health outcome indicator. We serve very largely as a resource for quality improvement assistance. So if you in your states are undertaking program work or activities where you think using a quality improvement approach would be beneficial, this is exactly what our organizations are set up to do. And again, you can find other quality improvement partners both nationally and at your state level. Many of you have them right in your own health departments with performance improvement specialists. But again, the unique thing, I think, a couple of unique things about improvement partnerships. First of all, we are focused very much on the care of children, adolescents, and families. And what we often find in, for example, hospital quality improvement structures is that the priorities are driven by who costs the most. And as many of you know, and especially when we're talking about preventive service delivery and routine care, the care that we deliver for children and youth, while it is highly effective and incredibly important, it doesn't cost nearly as much as paying for the care for an adult population, a state population of folks who have chronic diseases such as diabetes or heart disease or cancer. And so often what we find is that if we're not somewhat pushy and getting ourselves to the right tables, that children, youth, and young adults will really sort of get left behind when people are determining their quality improvement indicators and the focus for their QI work. IPs translate knowledge, so again, they scan the literature, they sometimes conduct the research, really look for those best practices and engage national and local colleagues to make sure that when we're testing new strategies, we're starting with the best practices. And then if we find things that work and if we have good outcomes from our projects, one of the things that we are that we pledge to do, that we're committed to doing, is disseminating those findings and really trying to spread the successful approaches. So that's one phase. And really, I think the final phase is taking that work and translating it into policies that will help systematize the work that we've done. So really trying to take what we learn from our project work and turn it into policies, whether it's at the state or community or hospital level, where doing the right thing becomes the default, so that you really don't even have to think about when to screen for chlamydia or when to conduct lipid screening or when to give an HPV immunization, but it's just built into your system so that it becomes the easy and the default thing to do. Another unique thing about improvement partnerships is that generally they are set up in a way that they become not only a convener but an honest broker. And what we try to do is maintain a neutrality in terms of value judgments about how people are performing. So we're not the insurer coming in to see if you're meeting your benchmarks and deciding whether you're going to get paid or not. We're not, in some instances, state government or the state Medicaid agency saying, did you conduct your EPSDT visits according to schedule? We know what those guidelines are, and we promote them, and we work to make sure that people are in compliance and alignment with them, but it's not our job to punish or, frankly, reward people other than the reward of knowing that you've done a good job and you've improved your performance. And finally, and I think this is an important carrot, I'm going to say a little bit more about this toward the end, we do provide opportunities for particularly our healthcare professionals to obtain CME, that's continuing medical education credit, or increasingly fulfilling specialty board requirements such as MOC, which is maintenance of certification. So health professionals who are required to do quality improvement work in order to maintain either their board certification and or their licensure. Generally, these organizations start with a home in something like an AAP chapter, sometimes a state Medicaid agency, departments of health, an academic institution, so a medical school, perhaps a children's hospital, or rarely in some other quality improvement organization. But these are generally the institutional homes of the improvement partnerships that are part of our network today. And geographically where they're located is shown on this map. So the green states are active improvement partnerships in 2017. The yellow states are ones that we've been in discussion and development with, but maybe haven't quite reached the stage of maturity of some of the others that you see. And then we sometimes do have some attrition. So the red states here, which says nothing about their political stripes, by the way, are ones that were active at one time but who have perhaps not been quite as active in the recent past. And we're always on the lookout for and interested in helping states that might be interested in developing these partnerships to do so. So if you think your state might be ripe to think about this, please contact me, and I'm happy to tell you how to get going. This slide shows the typical list of what IP advisory groups or stakeholders look like. And you'll see, again, it's many of the same partners that I've shown you on those other prior slides. So I'm not going to read through all these. I think one important one here that wasn't on some of the other slides is making sure that we're engaging parents and caregivers, and in the case of adolescents and young adults, the patients themselves in our quality improvement work. But generally, these are the same partners that you've seen listed earlier. And then back in 2008, we were fortunate to get some funding from the CHIPRA Quality Demonstration Grant Program that we were able to use to formalize a network among the existing, at that time, relatively small group of states. And so we were able to provide support to states that wanted to develop improvement partnerships at that time. And over the period of about 2008 to 2013, we actually almost doubled our number of members. And we're at about 25 right now, depending on who you count as in and who you count as out. And the other thing I should say is that there are many states that, while they may not have a formal improvement partnership, they have organizations or entities that look, for all intents and purposes, like an IP. So again, I don't mean to exclude those, and you may find those in your state if you don't have a formal improvement partnership. You also see here our website at the bottom. Wanted to show you quickly an array of projects. These are ones that I pulled out that are of special interest to folks working in adolescent health, and you can see they really cover the gamut from preventive services to mental and behavioral health, asthma, obesity. Many adolescent and young adult chronic illnesses are addressed, and mental and behavioral health, great focus on adolescent depression across many different states, immunization. So if you have a topic area for which you would like to conduct an improvement project, chances are there's someone in our network who may have already done something similar and would be happy to share their materials with you. And another one of our mantras is we're all about stealing shamelessly and sharing seamlessly. So we do give these materials away, and you can get them by contacting us, even if you're not a member of the network. But of course, we love it when new folks want to join the network and set up an improvement partnership. This is just a quick view of our resources. I'm going to skip right through this, but it will be available to you in the slides. And just a few of the lessons that we've learned from the work we've been doing for now, actually in Vermont, about 17 years. And then as we've increasingly expanded our network, we've really collected some evidence that would suggest that improvement partnerships, and I think your partnerships in general, and this goes back to that Institute of Medicine report, we can impact care as no single entity or agency is able to do. We convene those disparate stakeholders, and we align priorities and find solutions for common problems. We bring the expertise and experience together to those state policy discussions, and very importantly, provide a forum for sharing and learning across our network. And there's an article here, if you're interested in reading more about this, that you can take a look at that was a summary of our work back that, the work that we had done to date back in about 2012, 2013. So we're going to come to the closing portion of our talk today and really I want to show you just some concrete examples of how to take the background that we've already been talking about, in other words, thinking about those different potential partners, and then thinking about a quality improvement approach to improving not only health care delivery, but outcomes for the adolescent and young adult population. How can we take all that information and operationalize it in a way that is a concrete strategy to engage those partners and hopefully sustain some collaboration over time? So I'm going to use a Vermont example, and I don't mean to be too Vermont-centric today, but it is what I know, and so I feel comfortable sharing this with you. But there are many, as you saw on the map, many AAP chapters and improvement partnerships around the country that are doing this work. And if you're interested in knowing who's doing it in your state, please contact me, and I'd be happy to help you get connected. But Vermont, many years ago, took this concept of healthcare and public health integration and pulled together a group of people, starting with maternal and child health at the health department, that Vermont AAP chapter, and that eventually broadened to include many other state professional organizations. We were able to secure some grant funding between those two entities and really began to identify a common agenda of goals and objectives that we wanted to go after in terms of improving healthcare delivery and outcomes for the entire pediatric population, so the spectrum from birth to young adulthood. Again, a focus on the system of care. Our job was to find those tools that would help in this work, and then improving the communication and collaboration among the different entities. So we now, as I said, have broadened to include other partners. We have monthly meetings, and we continuously refine that common agenda and get then very specific about projects with objectives, activities, and deliverables. And our feet are held to the fire by those deliverables with firm timelines. And we're also able to be flexible enough to rapidly address emerging issues. So, for example, if you are in a state that is potentially exposed to Zika virus and you need to quickly, pull together a group that can address what do we want to say to our population of women and men, young men of reproductive health age, how do we address that group? This is the group that can quickly come together and say, what do we need, who do we need to pull in to the group, how do we deliver the messaging, what kind of project work do we need to do? And the interesting thing in this photo is that on this particular day, The group here includes many faculty from our College of Medicine, partners from the Health Department, including actually our Commissioner of Health and our Deputy Commissioner for Public Health. There's a state Medicaid agency representative here. So really quite an array of partners. Actually, I see some medical students and some residents. So, you know, it's a disparate group, but it brings together all the folks who care about this population. And we've expanded to include many different disciplines. I've already said we do annual planning that's data-driven. We're trying to improve our opportunity to engage patients and families, and I think we're getting stronger at that all the time. And so just to give you a specific example, one of the things that we did is work with our maternal and child health director, who has a wonderful strategic plan for the next 5 years, one indicator of which is adolescent well visits and community well-being. And so she has chosen the performance measure of that percent of adolescents ages 12 to 17 with a preventive medical visit in the past year. And she's identified some key strategies that can be conducted from the public health side. So working with schools, doing some community engagement and raising awareness. She's also interested in the percent of adolescents that feel that they matter to people in their community. So again, she's having her staff use the YRBS data to identify opportunities for work in school-based entities. And then we've pulled together a Youth Health Advisory Council to provide direct input into our project work to help move these indicators along. So that's kind of the public health side. But on our improvement partnership side, and this is simply our VCHIP mission statement and partners, so I'm going to skip right over that. What we've done is said, all right, we want to improve adolescent well care as well. The foundation for us is the Bright Futures Guideline for Health Supervision of Infants, Children, and Adolescents. And here you see the brand new 4th edition on the right just came out. We're going to be promoting that throughout Vermont and identified some grant funding to distribute that to many of our community partners. On the left is that dizzying table of all the things that health professionals are supposed to do at the different age visits in, by the way, 10 or 15 minutes, but I'm not going to dwell on that today. But that's our foundation. And then we built a network of healthcare practices, again, in conjunction with these partners, where we work together to take that health department indicator and we turn to the practice community and say, how can we do this on the ground? And we use a clinical practice-based quality improvement approach. We have a longitudinal measurement strategy, and we end up with a network that is able to help us carry this work out day to day, again, with very specific deliverables and time frames. And I'll just show you a little bit of where we've gotten to. You can see our network really covers the waterfront in Vermont, and you all know Vermont is very small, but we're pretty proud of the fact that we've got practices in every corner of the state because we're rural, and sometimes it's difficult to make those connections. We do an annual medical record review, and so we made sure to include that adolescent well visit as one of the indicators in our record review, along with the other topics that you see here, many of which are important in adolescent health care. And so just to show you sort of a quick snapshot of what happens at the end of one of these projects, we do the project work, and then both at the end of the project but annually, so that we can keep an eye on how sustainable our results are, we can look at things like at the very top you'll see adolescent depression screening, and this is aggregate results across our network by payer. You'll see health supervision utilization, and so you'll see actually we have quite a way to improve in terms of early adolescent health supervision visits. And then at the bottom you see across our network, again, health supervision utilization across all ages. And if you look to the right, you'll see a group of bars, the last 3 bars, 11, 12, and 13 years of age, or the early adolescent age group where we're at 63%, 71%, and 55% in the aggregate for utilization at the appropriate ages. So, you know, we like to think we do pretty well in Vermont, but clearly as you go up in age, those percentages fall off, and so we still have plenty of work to do to improve as well. So I'm going to end, and I'm going to run through these last 3 or 4 slides pretty quickly because my other strategy, in addition to forming a local partnership and really bringing the right folks together to work on these topic areas together, my other example is thinking about how can you align incentives for all the different groups that you want to bring to the table and use that as a lever to drive your improvement work. Lots of ways to identify incentives for health professionals. They are under pretty significant attack these days to keep up with the new and evolving structures for payment reform. They've got their educational objectives that they have to keep up with. They are now being monitored and paid based on whether they're meeting certain performance benchmarks. They need to do those quality improvement activities to meet their board certification, and just lots and lots of regulation coming at them. So if you can identify a common health improvement agenda that not only meets your need as an adolescent health coordinator or someone who's interested in that population with the incentives for health professionals, you've got a win-win, because you're both going to be working together and pulling with the same oar to try and get to those improvement objectives. And it's helpful, I think, to think about this not only for health professionals, but what do our patients want? And can we identify an incentive there that would help in this work? So I think a wonderful example of that these days is patients want a better experience of care, and adolescents and young adults are no different. In fact, they may be even more demanding of that in 2017. So bring them into the fold. Ask them what would improve the experience of care for them, but use standardized tools and a systematic approach to identifying what's currently going on, what do they want, and then how can you improve that. And using quality improvement tools and methods, you can measure what's happening now, do some improvement work, and then go back and measure again and see if you're getting to your objective. So patients become incredibly important in this work. But think about those other partners, the payers, and as I said earlier, they're beholden to certain benchmarks, and they're competitive. So if they can improve the experience of care for their own beneficiaries, they're going to be more competitive in the current world than their neighbors. So think about what incentives might align there. And then finally, what do you, either as government employees and or your government partners, want? And certainly you are on the dime for accountability in terms of the value for the public funds that we're expending, and very interested as well in improving performance and the outcomes for the population that you serve, with a special focus on underserved populations and improving coordination of services. Having done this work for 15 to 17 years, we have collected perspectives over time, and these are the kinds of things we hear from these different groups. Health professionals really do want to improve care, but they need help to do that. And so if you can identify ways that you can be the wind at their back to achieve all of the things that you see on this slide, you will have them at the table in a heartbeat. It's all about thinking about the incentives for them. We mentioned state government, and again, if you can design your programs and activities so that you can help your state partners meet these benchmarks, again, a real win for everybody. And insurers, as we said, again, it's about the benchmarks, it's about being competitive in a very complex world of healthcare delivery, but also very much wanting to improve healthcare delivery efficiency and effectiveness. So the keys to success that I'm going to leave you with, I think it's a no-brainer that convening interested stakeholders to align these priorities and find solutions for the common problems, and really trying to do so in a way that's relevant for all stakeholders, so not just for one of those groups, will really get you far down the path to healthcare and outcome improvement. Go out and look for those clinicians and other interested stakeholders. The clinicians may seem busy, and you know, if they don't return your phone call, don't take it personally, and find a way to work your way in through perhaps the door of the professional organizations, I think particularly in primary care. And finally, I think if I leave you with one message, it's the idea, and again, back to that Institute of Medicine report, that public-private collaborations impact care and outcomes as no single entity possibly can. So here is the contact information for Kristen, and my great thanks to Kristen, who has been the organizer of this series and really helped connect us here at the Vermont Child Health Improvement Program and NIPN and the Adolescent and Young Adult Health National Resource Center, to you all who are doing this work on the ground and trying to identify topic areas that would be of interest. So please don't hesitate to contact us with questions or feedback. And I think we have a couple of minutes, and I know Kristen needs to share a couple of slides as well. But thank you very much for your attention today.
Thank you, Wendy. That was wow, that was a lot to think through and process as we look into our own communities, our own states, and the work that we're doing through partnership. So I just want to just throw out, as we're getting our last ideas together, which of your partners are the hardest to get at the table? Anybody want to share anything on partners that you've been working with to get to the table that you're like, oh, we never find the common ground, or they come and we miss them somehow or another? Anybody want to share something on that, please? Either type into the chat box or press #6 on your phone. Give yourself a second, and your phone should be live to be able to talk. Of course, if you have any other questions or comments or suggestions about things that you're doing, we'd love to hear that too.
Hi, Kristen. Can you?
Yeah.
Hi, this is Cynthia in New Jersey.
Hi, Cynthia.
Hey, from the time that we submitted our IA application, we've just really had a challenge with getting a Horizon representative to make a commitment to be a part of our IA coin, and they're the largest insurer of our Medicaid population. So, yeah, I actually have like one of my partner grantees also following up through her agency to see if she can help us. But yeah, I'm just shocked. So I don't know if anybody has any tips of how to make that connection.
Cynthia, this is Wendy. I don't know. I certainly know New Jersey and your application and your wonderful improvement partnership. I'm so excited that you're doing this. Is the way Horizon is connected to Medicaid, is it in such a way that you could reach out directly to either your EPSDT director, your state Medicaid director? I mean, I could give you a suggestion of a couple of different categories of state Medicaid agency personnel to start with who could then maybe be a little bit of an intermediary, but have you tried that? And would that work given the way things are set up, do you think?
Yeah, it's funny because as you were going through your slides, I actually made a note about the EPSDD director. So we have a new director for our MCH program. She's just started in the last 2 weeks. So I was going to connect with her and suggest to her like us reaching out to EPSDD.
I think that's a good idea. And the other thing is, what we've sometimes done in the past, if you can, like if you want our Vermont EPSDT director to talk to your EPSDT director, sometimes that colleague-to-colleague connection is really the spark that gets it going, because that person can articulate even better than we can what the potential benefits are. So don't hesitate to let me know if whoever you're reaching out to, we could figure out the counterpart in a couple of different improvement partnership states and see if we could get somebody to talk one-on-one with them.
I appreciate that so much. Thank you for that offer.
Certainly.
I'll let you know. I'll try first with my director and director to director, and then we'll see if we need to go further.
Great.
Thank you.
I do want to note that we have a note from Marcella in Illinois in the chat box about they're starting a new Adolescent Health Advisory Committee, which sounds really exciting, but they're having a hard time getting their Medicaid folks to respond and become engaged. Wendy, do you have any suggestions, or does anybody else have great ways that you've gotten your state Medicaid people to the table? I know they have lots of competing interests in their world.
This is Wendy. You know, it's interesting, and I'll just say quickly while other folks are thinking about that. It's a little, I think it's similar to what I just said to Cynthia. So I think it's, sometimes identifying the right people, but then we could do a state-to-state connection. The other thing it's just interesting that these are both, we're talking about Medicaid entities, and I suspect in some ways right now they're a little bit reeling from just trying to figure out the world around them. But again, Marcella, if you wanted to send me an email, I could send you some ideas for talking about what the incentives are for Medicaid that might catch somebody's attention. And again, maybe making that personal colleague-to-colleague connection from Medicaid reps from different states might help. I'd love to know, though, if anybody else does have any strategies. This is Wendy. I just have one more thought. It's interesting. We have in our state something called a Pediatric and Family Medicine Council, where it's a legal structure to kind of talk about payment and healthcare delivery issues. And Medicaid here has actually been more consistently participating than we've had trouble with our commercial insurers. So I think, again, this is one of those things where it's often a local issue.
Can I just throw out this is Kristen, another thing just to keep in mind, a lot of times it is personal relationships that gets people to the table. So if you know anybody that knows anybody that knows anybody that has a personal relationship with somebody in Medicaid or an insurer, sometimes that helps grease the wheels to get them at the table. The other thing is sometimes people just aren't ready. It's just not the right time. And looking for alternative ways to keep them connected, to keep bridges to them, to keep communication open with them, so that as things are evolving in your partnership, they might be brought in a little bit later, or as new opportunities open up, they might want to get involved or have the ability to get involved. So I think sometimes just saying, hey, respect you can't be participating right now, but we just want to keep you on top of what we're doing. And let us know when you have questions. We'll just check back with you.
Kristen, just quickly, this is Wendy. I'm seeing that Kason Benton, who's our great partner in Alabama, typed in the Chipper Child Core Set and adolescent visits. And I think, and Kason, I don't know if you can unmute, but I think you're saying that as a response to an indicator that Medicaid would be interested in improving, and that might be the incentive. I hope I'm interpreting that correctly. And it's #6 to unmute.
Well, we have hit the hour, so if you would like to stay on and ask any more questions or make some comments, please feel free to.